Mr. Puneet. Yes. Thank you very much, Mr. Puneet. I hope I am audible to everyone.
Yes, sir.
Okay, thank you. So at the outset, I'd also like to thank Dr. Vijay Kher for this very kind invitation to me to join you all once again in this Thursday evening session after a long gap. And today, the plan is to take you on a journey from acute renal failure, as we knew this entity when we were students, to acute kidney injury, as it is called now. So a lot has changed over the last 4 decades, and I'll go over that as we discuss the subject. May I have the next slide, please? So first, let's start with the old definition of this condition. So when we were students, for us, the definition was simply a sudden decline in renal function. How sudden was left unspecified. And this sudden decline was associated with a rapid rise in urea and creatinine levels. And this was associated with a decrease in urine output in some of these patients, but not all. And there was no staging of acute renal failure that was laid down at that time. Currently, of course, all of you know that the terminology has changed. So, whereas earlier it was only acute renal failure that was taken into consideration. That means the kidney had totally failed and the patient was usually dialysis dependent. But now we recognize there can be much milder forms of acute kidney damage or acute kidney injury, as we call it now. And that is one of the reasons why the terminology has changed. Till 2004, there was no staging of acute kidney injury. And it was only at this stage that the rifle staging came into existence. And this was based on 3 criteria: the urine output, the serum creatinine, and as an alternative to the serum creatinine, you could also use the GFR. And there were 5 stagings according to which it was called rifle: risk, injury, failure, loss of renal function for 4 weeks, and finally end-stage renal disease lasting more than 3 months. So that is what rifle stood for. However, it was soon realized that measuring the GFR in patients with AKI is difficult, because the GFR is frequently changing, and from the creatinine alone, it's not possible to accurately measure the GFR, because changes in the creatinine occur later than changes in the GFR. And therefore, this staging was soon replaced in 2007 by the Akin staging. And the Akin staging was then slightly modified by KDIGO. And may we have the next slide? So this is the KDIGO definition and staging of AKI, which is currently in use all over the world. And you have now 3 stages, not 5 stages. So stage 1, now, and each stage is defined by the serum creatinine elevation over the baseline levels and the urine output criteria. So GFR is no longer a criterion. So in stage, and there were 3 stages. Stage 1 is a serum creatinine rise of at least 0.3 milligram per deciliter, and this rise should occur within 48 hours, or the creatinine may rise 1.5 to 1.9 fold above the baseline within 7 days, and the urine output criteria are mentioned alongside. And in stage 3, the serum creatinine should be more than 4 milligram per deciliter, or the patient should become dialysis dependent, and the urine output was less than 0.3 ml for more than 24 hours, or there was anuria. Now, this staging is to be applied only after fluid repletion, if fluid repletion is indicated when the patient first presents to you. For this staging, we should know the baseline creatinine, and the baseline creatinine needs to be normal, because if it is not normal, then it is acute on chronic kidney disease. And you need to classify the patient according to the most severe criterion that the patient has exhibited. For instance, if the patient is already anuric, even if the creatinine rise is only 0.3, it becomes stage 3. It's also important to understand the difference between AKI and rapidly progressive renal failure. In AKI, the rise in creatinine or the fall in urine output occurs over hours to days, whereas in rapidly progressive renal failure, the rise occurs over days to weeks. So this difference is important to remember. The next slide, please. Now, there are several risk factors that predispose patients or increase the risk of a patient developing AKI. And this is a list of some of those factors. It's not a complete list. So elderly individuals, males, diabetics are all at increased risk. Those with malignancies have a higher risk than usual, because malignancies by themselves can involve the kidneys in various ways. And on top of that, the chemotherapeutic agents used for treatment, there is an increasing number of chemotherapeutic agents, right down to the immune checkpoint inhibitors, which are the latest to join the list, which can cause nephrotoxicity. So these patients are at a tremendously increased risk. Patients with chronic liver disease frequently develop what is called hepatorenal syndrome, and I'll discuss that also briefly at the end. Patients with cardiovascular disease often develop renal problems because of a low cardiac output or arrhythmias or various other mechanisms. Patients with chronic kidney disease and proteinuria are very prone to develop superimposed episodes of AKI. Those undergoing cardiac surgery or any complex prolonged surgery are at risk for AKI. And finally, those who have sepsis. As you'll see, sepsis is one of the commonest causes of AKI. Now, coming to the various ways in which AKI is classified. There are various classifications, right from the older ones to the newer ones, and I'll briefly go over all of them because they all have their own importance. So one of the first ones that has been in use for a long time is the classification into pre-renal, renal, and post-renal causes. Now, this is a very important classification because it helps you to understand the pathogenesis of AKI also. When a patient becomes hypovolemic or hypotensive for any reason, supposing a patient comes with diarrhea, vomiting, gets dehydrated, that can lead to what is called pre-renal azotemia, which is associated with a decline in urine output and some rise in urea and creatinine levels. Now, if within the first few minutes or hours, if you quickly correct that hypotension or hypovolemia, the process is reversed and the patient recovers his urine output. The urea and creatinine levels come back to normal immediately within a few hours, and he does not go on to develop intrinsic renal damage. So pre-renal azotemia is a functional form of renal failure as we understand it currently. However, if this process is not taken care of quickly, the hypotension persists beyond a certain point of time, it goes on to cause intrinsic renal damage, in which structural damage also has taken place. And finally, there is a post-renal injury, which is characterized by intratubular or lower urinary tract obstruction. Then yet another way of classifying AKI is into the setting in which it occurs. So you can have community-acquired AKI and you can have hospital-acquired AKI. And in turn, hospital-acquired AKI can be divided into patients which are in an ICU in the hospital or in a non-ICU setting in the hospital, right? So community-acquired, an example of, no, please stay on that. So community-acquired, just to give you an example, supposing somebody develops supposing somebody develops an episode of diarrhea and vomiting at home, so that's community-acquired acute renal failure. Or somebody develops falciparum malaria and then reaches the hospital. Or say an infection like leptospirosis, or somebody has a snake bite in the fields. So these are all examples of community-acquired AKI. Whereas if a patient is already admitted to hospital for some illness, irrespective of what is the illness, and more than 24 hours after admission to hospital, he develops a decline in urine output or an episode of hypotension or an arrhythmia or anything, any event which leads to AKI or sepsis within the hospital, that's hospital-acquired AKI. And this is very common in the ICU setting, where 20 to 30% of patients will develop AKI. In the non-ICU setting also, something like 10 to 20% of patients can develop AKI. So community-acquired patients with AKI, generally the etiology is a single one. It's not multifactorial. These patients are often young. By the time they reach the hospital, it is quite late, and they are often in a stage when they require dialysis. Whereas in the hospital-acquired variety, it's very often multifactorial. The rise in creatinine is much less than seen in community-acquired because it's detected early, the patient is already in hospital. But there is often multi-organ failure in these patients, and these patients tend to be older than those with community-acquired AKI. The next slide, please. Now, yet another way of classifying AKI, and this largely applied to dialysis-dependent AKI, because most of the series that were published in the early 90s and so on, there were series of patients who had dialysis-dependent ARF, so to call it. And this was one large series that we published. And in this, nearly 2/3 of all patients had a medical cause for their underlying ARF, like renal hypoperfusion because of any cause of hypotension, hypovolemia, glomerulonephritis, intravascular hemolysis in a setting of G6PD deficiency, sepsis, drugs causing acute tubular necrosis or acute interstitial nephritis, snake bite, which accounts for about 5% of all ARF, falciparum malaria, leptospirosis. Surgical causes of acute renal failure accounted for about 30%. These included post-operative AKI, post-traumatic, that means after following roadside accidents, and obstructive nephropathies, and obstetric AKI, which is an entity which we see only in developing countries like India. The developed world does not see this. And this accounted for about 6% of patients at that time. The figures have decreased further even now. And the causes include septic abortion, preeclampsia, abruptio placentae, postpartum hemorrhage, and puerperal sepsis. The next one, please. Yeah. Now, yet another important classification is into oliguric and non-oliguric AKI. So patients with oliguric AKI have a urine output of less than 500 ml per day, whereas those who have non-oliguric AKI have a urine output more than 500 ml per day. And these patients have less severe injury, they have a lower mortality, and a much lesser need for dialysis. Amongst the oliguric patients, there is a subgroup who can be labeled as anuric, and in them the urine output is nil or less than 100 ml per day. And in these, the differential diagnosis, the first one obviously is urinary tract obstruction, but the other ones that can be associated include acute cortical necrosis, crescentic GN, thrombotic microangiopathy, and the rare entity of mucormycosis. In some patients, you may have a very wide variation in day-to-day urine output, and in such patients, the etiology is almost always urinary tract obstruction. The next slide, please. And finally, coming to this very important classification into functional versus structural lesions. So functional acute renal failure occurs in pre-renal azotemia, which I referred to earlier as well. It can also occur in a condition like hepatorenal syndrome. And finally, drugs like ACE inhibitors or ARBs or NSAIDs can sometimes cause a functional acute kidney injury. In ACE inhibitors, ARBs, it's generally due to loss of the efferent arteriolar vasoconstriction, whereas with NSAIDs, it is due to prostaglandin inhibition. Now, coming to the structural lesions, so there is a wide variety of structural lesions that can be associated with renal AKI or intrinsic renal damage. And the commonest of these is, of course, acute tubular necrosis, which accounts for something like 60 to 65% of all patients. This can occur as a result of ischemia, intravascular hemolysis causing hemoglobin nephrotoxins like aminoglycosides or sepsis. Acute tubulointerstitial nephritis, also not uncommon, accounts for about 10 to 15% of all AKI. And this entity is largely due to drugs. And then you can have rapidly progressive glomerulonephritis, vasculitis, acute cortical necrosis, hemolytic uremic syndrome, tumor infiltration of the kidneys, as can occur in lymphomas and leukemias, cast nephropathy, which typically occurs in myeloma, and finally, crystal associated nephropathies. The next one. Now, how does AKI in the tropics differ from that seen elsewhere? So, firstly, the etiologic spectrum is very different. There is a wide range of infections that we encounter in the tropics that the developed world does not see. For instance, in Kerala and Tamil Nadu and some parts of Western India, we often encounter leptospirosis. Snake bite is very common in some parts of Kerala, for instance, and Tamil Nadu again. Obstetric causes are seen in India, not at all seen across the developed world. And even within the tropics, there is a lot of heterogeneity in the spectrum. For instance, in the northeast of India, you'll see a lot of falciparum malaria, which you don't see in so much in other areas. AKI is commoner in the tropics, accounting for 1.5% of all hospital admissions, as compared to only 0.1% in the temperate zones. Community-acquired AKI is commoner than hospital-acquired AKI in the tropics. The mean age of patients is much lower, 34 years versus 60 years. And in the tropics, patients tend to come to the hospitals very late in the course of the illness. The next slide, please. And this is just to give you some idea of the spectrum of AKI as seen in India. Now, this is a study that was from JIPMER Pondicherry, and this included 186 patients of community-acquired AKI. The mean age was only 46. You can see that 60% of these patients were non-oliguric, 40% were oliguric. Infections accounted for 46%, or the large majority of all patients. And surprisingly, in this study, the commonest infection that accounted for AKI was pyelonephritis. Now, I'd like to emphasize that this is not typical of the whole country. So pyelonephritis would account for not more than 5% of all AKI in my experience. So it's not so common in series from other centers. Pneumonia, of course, was the second most common cause of an infection which was associated with AKI. In this series, snake bite accounted for as many as 26%. So this is an area where snake bite is fairly common. And as you will see in this series, the mortality in community-acquired AKI was only 15%, which is in contrast to the next slide, where you see the spectrum of hospital-acquired AKI in the ICU. And in that, you'll see the 30-day mortality is 52.5%. So more than 3 times the mortality that you saw in community-acquired AKI. Now, this study is again from JIPMER Pondicherry. Data collected between 2013 and 2015. This included 236 patients, 73% were males. Almost an equal number who had community-acquired and hospital-acquired AKI. The commonest causes of AKI were sepsis, trauma, acute abdomen, and cardiac causes in that order. The hospital-acquired patients were younger, the more surgical cases, they had lower SOFA scores, lower serum creatinine, a lesser need for dialysis, and a longer hospital stay. The mortality I've already referred to. The next slide. Now, when you see a patient with AKI in the emergency, for instance, you often need to distinguish AKI from CKD. So how do you do that? Well, most of the time, the history alone is good enough. If a patient has a long history of hypertension or a long history of proteinuria, frothuria, a long history of edema, then it becomes easy. Then this is CKD rather than AKI. If you have a clear-cut precipitating factor, like an episode of hypotension, hypovolemia, with a clear-cut cause like diarrhea, vomiting, etc., then it's likely to be AKI. The presence of a normocytic normochromic anemia is a strong pointer towards chronic kidney disease. The presence of half and half nails, which I'm sure you're familiar with, are a pointer to CKD. Similarly, the presence of peripheral neuropathy, mineral bone disease, small contracted kidneys on ultrasound, or left ventricular hypertrophy on ECG or echocardiography, and the presence of hypertension are all features that would favor chronic kidney disease. The next slide, please. So the first step that one should resort to is examination of the urinary sediment. This can give you a lot of clues. So the presence of a lot of RBCs or RBC casts with significant proteinuria would suggest rapidly progressive glomerulonephritis. Presence of WBC casts would suggest pyelonephritis, whereas the presence of dirty brown granular casts and lot of tubular epithelial cells in the sediment would suggest acute tubular necrosis. Presence of crystals should suggest a crystal nephropathy, and broad casts would suggest chronic kidney disease. An ultrasound of the abdomen is required only to exclude urinary tract obstruction and to exclude contracted kidneys, which of course, as I said earlier, would indicate chronic kidney disease. In patients with acute tubular necrosis, the kidney size in most patients would remain normal. In some conditions like acute pyelonephritis, there can be enlargement of some degree of enlargement of the kidneys. CT scans are very rarely required in patients with acute kidney injury. Now the next slide. So this shows you the urinary indices that were often used earlier to distinguish prerenal azotemia from acute tubular necrosis. Now, you can still use them, but we don't use them too much nowadays because the examination of the urine sediment is a much better parameter. Moreover, these last 2 points are most important. In prerenal azotemia, you get a good response to a fluid challenge. The process is reversed and the urine output improves rapidly, whereas in acute tubular necrosis, which is an intrinsic form of renal damage, fluid challenge does not reverse the process. In prerenal azotemia, 2 points that are important to remember: the urea is increased out of proportion to the serum creatinine. In other words, the serum creatinine may rise not more than 2.5 or 3 milligrams per deciliter, whereas the urea may be something like 150. So the urea is out of proportion, right? So these are two clues to the possibility that you're probably dealing with pre-renal azotemia. The next slide, please. Now, coming to the issue of biomarkers for AKI. When troponin T and troponin I were identified as biomarkers for myocardial injury in patients with myocardial infarction, it was suggested that maybe we'll be able to find some such markers or troponins, renal troponins, in patients with AKI. And the search began. And the search has been ongoing for 2 decades. We recently had an AKI conference organized by nephrologists in Delhi, in which there was a debate on biomarkers for AKI. And I remember Dr. Khuller was one of the persons who still had the optimism to say that maybe in the near future we'll have some biomarkers. Whereas at the same debate, I had said that the research has been already going on for too long. We've reached nowhere despite all that. Acute kidney injury is much more heterogeneous than myocardial infarction. In myocardial infarction, it's just straightforward muscle injury, whereas AKI can be due to injury to a variety of tissues like glomeruli, blood vessels, tubules, interstitium, or a combination of these. And therefore, it's not likely that we will find any reliable biomarkers for AKI. So we might as well give up the search, in my opinion. The next slide, please. So this is just to tell you about the phases of acute tubular necrosis. So the initiation phase lasts for up to about 24 to 48 hours. That is the phase during which there is hypovolemia or hypotension. And in that much time, generally that phase has been corrected or reversed. And if the patient does not respond to that, he's already in established ATN, so he remains oliguric. This oliguric phase can last for up to 3 weeks, after which a diuretic phase ensues and may take another 1 to 3 weeks. And after that, the patient, during the diuretic phase, the recovery begins, and the renal failure, the acute kidney injury may recover. So the total course can range from a few days to as long as 8 weeks in these patients. The next slide, please. Now, why do these patients become oliguric? There are 3 explanations. In the initiation phase, there is a reduced renal blood flow and a GFR. Subsequently, the oliguria is because of tubular obstruction by T-squamated epithelial cells and casts formed by these epithelial cells. And finally, there is also rupture of the tubular basement membrane. And because of that, the glomerular filtrate leaks into the interstitium of the kidney. So all these factors can contribute to the oliguria that we encounter. The next slide, please. Yes. So now I'll go on to the management in patients with suspected acute tubular necrosis. I'm focusing on this because this is the commonest cause. So the first thing to be done is to assess the blood pressure and the volume status once the patient comes in, and carry out fluid repletion if needed. You can look at the blood pressure, look at the central venous pressure, look at the hydration status. You can look at the IVC diameter and its collapse. And after fluid repletion with normal saline, with crystalloids rather, if necessary, if the urine output does not improve, you can challenge the patient with one dose of a loop diuretic, one bolus, and see if the urine output improves. However, if the loop diuretics do not help, then there is no point continuing them, right? Because then you'll be just wasting the drug. Now, if the blood pressure comes up, or rather does not come up enough with volume repletion, patient remains hypotensive, then you may need vasopressors like norepinephrine and sometimes vasopressin also, depending on the requirement. While you're doing all this, it's important to monitor the body weight and the urine output, and the fluid intake of the patient at this stage depends on these two parameters. You need to immediately look for hyperkalemia, acidosis, and pulmonary edema, because if you have any of those, then those are immediate indications for an urgent dialysis, which can prevent mortality in these patients. So that's very important. The nutrition during the oliguric phase. In non-catabolic, non-dialysis patients, a protein intake of about 0.8 to 1 gram per kilogram is sufficient. But in dialysis patients, you need 1 to 1.5 gram per kilogram. The doses of drugs such as antibiotics needs to be more modified depending on the glomerular filtration rate, and you take care of the primary disease that has resulted in AKI. For instance, if it was malaria, you treat the patient appropriately. If it was a drug which led to AKI, you withdraw the drug concerned. You may need to give steroids if it's a drug-induced interstitial nephritis, and so on. So whatever appropriate treatment for the primary disease is required, you start that. The next slide, please. Now, the next issue is, when should you initiate dialysis if required? So if the potassium level is already more than 6, or the pH is less than 7.15, or there's pulmonary edema, or there's encephalopathy, or there is a fluid overload as indicated by a greater than 10% increase in the body weight over the baseline levels, these are all indications that you need to go for immediate dialysis, and you do that using the internal jugular vein for vascular access. I do not recommend the femoral vein. Only in rare instances, if you have a bedridden patient in the ICU, yes, you may use the femoral vein. Otherwise, I would prefer to use the internal jugular vein for access. So in all these situations, prophylactic dialysis improves survival. There is, however, no consensus on the degree or duration of oliguria. That is an indication for starting. However, I would not take a risk. So if the urine output is less than 200 ml for more than 12 hours or less than 100 ml for more than 8 hours, I would go ahead with dialysis, because if I don't, then I am putting the patient at a risk for the development of an urgent indication, and thus increasing the risk of mortality. Nevertheless, may I have the next slide, please? There has been a lot of debate as to early versus late initiation of dialysis. Does early initiation really improve the outcomes? So there have been several studies. The first one was the Elaine study, but I won't discuss this any further because it's been criticized that it was a comparison of very early versus with early initiation, and therefore is not really worth considering at all. Then there was the Acute study, and this showed initiation at stage 3 versus later did not make any difference to the mortality of these patients. So you don't need to initiate dialysis before stage 3 in any case. The next slide, please. And then there were two more studies after that. The ideal ICU trial, which was a multi-center randomized control trial in sepsis-related AKI. And these patients received dialysis either at stage 3 or 48 hours later. And in this study also, the mortality in the early versus the late groups was not different. And so early initiation did not reduce the mortality. And finally, may I have the next slide? In the START AKI study published in 2020, again, an early start was not beneficial. So therefore, starting dialysis before stage 3 in any case is not required, but you may need to be sure that you don't delay it, that you end up with mortality. The next slide, please. Now, what is the kind of dialysis modality that you should use? When we were students, the first dialysis that was done in most of these patients was a peritoneal dialysis, because internal jugular access was not available at that time. We used to use arteriovenous shunts, and it used to take a vascular surgeon to create those shunts. So therefore, we often did peritoneal dialysis to begin with. However, this is now seldom used. This is only used in places where hemodialysis is not available, or in small children in whom vascular access is difficult. So nowadays, if the patient is hemodynamically stable, we would go for intermittent hemodialysis. We do this thrice a week. Whereas if the patient is hemodynamically unstable, then we would generally do SLED. CRRT can also be done. However, SLED has numerous advantages in a developing country, being much cheaper, much shorter, less nursing supervision required, much less anticoagulant dose required, so much easier to perform in a developing country. CRRT alone would be okay for if you're dealing with hepatic failure patients because of the risk of cerebral edema. And we continue dialysis on an alternate day basis, usually till the diuretic phase begins. And at that stage, once the patient's general condition starts improving, the creatinine starts declining, and the patient is not symptomatic because of uremia, you can discontinue dialysis. The next slide, please. Now coming to the issue of renal biopsy. Now, when you have a clear-cut diagnosis of acute tubular necrosis, you do not require a biopsy at all. However, in patients in whom you do not understand the cause for acute kidney injury, or there is a possibility of rapidly progressive glomerulonephritis or vasculitis, or drug-induced acute interstitial nephritis, all of these are immediate indications for specific therapy. And in all of these, an early kidney biopsy should be done. A late kidney biopsy may be required only in those patients who remain oliguric for more than 3 weeks, therefore raising the possibility of acute cortical necrosis, and that's another situation where a biopsy may be indicated. The next slide, please. The next one, please. Yes. Now, if you do a biopsy in a patient with ATN, you find that the tubules are dilated, they're lined by flattened epithelium, there are apical blebs, there is cell debris and casts in the lumen, there's some degree of interstitial edema. The term necrosis is actually a misnomer, since it affects only 10 to 15% of tubules. And there is a lack of correlation between the severity of histologic changes and the functional status. And therefore, you should call it really acute tubular injury rather than acute tubular necrosis. Mitotic figures in the tubular epithelium are evidence for tubular regeneration. The next slide, please. Coming to the mortality and prognosis. Now, the mortality therefore varies widely depending on the setting in which you see a patient. It may be just as low as 20% or 15%, and it may be as high as 70%. The GFR gradually returns to normal after recovery in about half of all patients, does not return to absolutely normal, and it may take several months to reach that level. The prognosis of the patient depends on the patient's age, the cause of AKI, the presence of oliguria, the severity of AKI, presence of sepsis, number of failed organs, and the comorbid conditions that these patients might have. Now, the next slide, please. One very important condition that we did not recognize earlier is the risk of developing chronic kidney disease after so-called recovery from an episode of acute kidney injury. Now, we obviously know very well that patients with acute cortical necrosis or a RPGN can certainly go on to develop CKD later, soon after the episode. However, what about patients with acute tubular necrosis? Do they go on to develop CKD later in life? This is something that we did not realize earlier. We thought that all of them recover completely, but now we know that at least some of them can develop CKD later in life. Now, how many exactly will develop this? We don't know. One study showed that after 5 years, 9% will develop it. And the ACR is one of the risk factors that can predict. However, the mechanisms that are responsible for this CKD are not clear. So there's a new terminology that has been decided on. So we call AKI as transient if it is reversible within 48 hours. We call it persistent if it reverses in 2 to 7 days. And if it doesn't recover even in 7 days, then we call it acute kidney disease up to 3 months after the episode. So the recommendation is that check the serum creatinine of the patient at follow-up 3 months after discharge from the hospital, so that you do not miss the possibility of CKD developing after an episode of AKI. The next slide, please. A brief word is important to be mentioned about acute cortical necrosis. Now, this accounted for about 3.8% of all dialysis-dependent ARF in India when this paper was published many years ago. And obstetric causes were responsible for more than half of these patients. These were all due to septic abortion, abruptio placentae, preeclampsia, and puerperal sepsis. Besides obstetric causes, snake bite accounted in 14%, HUS in 11%. The diagnosis can be confirmed by biopsy and by contrast-enhanced CT scan, and only about 20% of these patients are independent, go off dialysis 3 months after the onset of the episode. The next slide, please. Now, my presentation would be incomplete if I didn't talk about myeloma, because myeloma is one condition in which renal failure can be a presenting manifestation in up to about 10%, and renal failure occurs at some point during the course of myeloma in up to 25 to 50%. So in any unexplained renal failure where you don't understand the cause of renal failure, you must always look for a myeloma. Disproportionate anemia and hypercalcemia are clues to this possibility. The investigation that you should do should include a serum protein electrophoresis and a free light chain assay. The most common lesion that underlies this kind of AKI is a cast nephropathy, and there is still a controversy as to whether plasma exchange is useful in reversing such a kind of AKI. The next slide, please. Yes. Now, mucormycosis is a rare cause of acute kidney injury, but something that one should not forget. These patients can present with fever, lumbar pain, hematuria, and anuria. And this is because the fungus is angioinvasive, results in thrombosis of large and small arteries, resulting in massive renal infarction, which is bilateral, and that is what gives rise to the hematuria and the anuria. This has been reported extensively from the PGI Chandigarh, where we have seen a lot of patients. This occurs even in immunocompetent patients, possibly due to contaminated IV fluids given in the periphery. The diagnosis can be made by CT scan. In patients with isolated renal involvement, bilateral nephrectomy and amphotericin therapy may be life-saving. However, in patients who have disseminated mucor, the condition is usually fatal. The next slide, please. And the last two slides are on AKI in liver disease, because there have been new developments in this area. Hepatorenal syndrome is a functional form of AKI, which occurs as a result of renal vasoconstriction in the setting of splanchnic vasodilatation. And the earlier classification divided AKI in HRS into HRS1 and HRS2. However, this classification has now been modified. So we have HRS AKI, in which the serum creatinine, in line with the current KDIGO criteria, has risen by more than 0.3 milligram per deciliter over 48 hours, or the urine output is less than 0.5 ml per kg for more than 6 hours. And the other category, that is HRS2, is now labeled as HRS non-AKI. So these patients either have AKD, acute kidney disease, with a GFR less than 60 ml for less than 3 months, or chronic kidney disease with a GFR of less than 60 ml for more than 3 months. Now, the precipitating factors for hepatorenal syndrome, the most common is large volume abdominal paracentesis without albumin support. And of course, the other important one is a spontaneous bacterial peritonitis. Sometimes an upper GI bleed can also precipitate HRS. And my final slide is on an entity. The next one, please. Last slide. Yes, there we are. Maybe go back to, yes, there, that's it. So bile cast nephropathy. Now, this is an entity that was recognized even earlier and was given the name cholemic nephrosis in 2015 and 2016. And it has been revived more recently. So whenever acute kidney injury occurs in a setting where the serum bilirubin is more than 15 to 20 milligram per deciliter, and this may occur in patients who have liver disease such as obstructive jaundice or cirrhosis with HRS or drug-induced liver disease, these patients are characterized by tubular obstruction due to pigmented bile casts in the distal tubules along with tubular necrosis. And so this condition is called a bile cast nephropathy. It may reverse only if there is a decrease in bilirubin with improvement in liver function. One recent study has shown that plasma exchange may help these patients. So, and bile cast nephropathy is therefore a structural form of kidney disease that may account for something like 20 to 30% of all patients with a so-called hepatorenal syndrome. So hepatorenal syndrome may not be entirely a functional disorder. It may also be associated with structural injury in the form of a bile cast nephropathy. So that's my last slide. That's where I'd like to stop. And now it's open to all of you for your comments and questions that we can take up. I hope I'm audible. Puneet, I don't see
Yes,
you.
sir. Yes, sir. Yes, sir.
Yes. So in case anybody has any comments, any questions, even if you have any questions later on, you can get in touch with me through my email, and I'll take up all your queries.
So there's one in the chat box.
Yes, on preeclampsia AKI. Yes, what exactly you would like to know about preeclampsia?
So it says pregnancy AKI postpartum, how to diagnose whether is TMA or HELIP.
See, for diagnosis of hemolytic uremic syndrome, whether it is pregnancy related or unrelated to pregnancy, you need to first look at the peripheral smear to look for schistocytes, that is fragmented RBCs. Second thing you need to look for is thrombocytopenia. Third thing you need to look for is the LDH level. So these are the three primary things. So look at the hemoglobin. Has it dropped? Are there fragmented RBCs in the peripheral smear? Is there a thrombocytopenia? Is there an LDH elevation? If you have these findings, then obviously you have the clinical features that can fit with an episode of thrombotic microangiopathy. And if these features have already disappeared by the time the patient comes to you and the patient is in renal failure, the next step would be to do a kidney biopsy to confirm the diagnosis of TMA. If you have these features, then it's not necessary to do a biopsy for the patient. So a biopsy would be the other step. And finally, to establish whether this is a typical or an atypical hemolytic uremic syndrome, you need to look at the complement levels, the complement dysregulation TMAs. So you need to investigate for those. So you need to look at factor H, factor I, membrane cofactor protein, and so on. So there are numerous abnormalities in the complement dysregulation type of TMA, which you can look for. And if you find any of those, then it obviously gives you a clue to the type of TMA that you are dealing with.
So there's another question. What
Yes.
are your experiences with bilateral nephrectomy after mucormycosis? We lost our 2 patients even after removal of kidneys after 4 days of disease onset.
See, ideally, you should do an autopsy in those patients to find out whether they had disseminated mucormycosis or did they have any other bacterial sepsis associated. That would really establish the cause of death in those patients. Without that, it would be extremely difficult. One would only be guessing. But my suspicion is that if you lost your patients, then most likely they had disseminated mucormycosis.
Another one, sir. When should we biopsy the patient for ATN? 4 weeks or wait till 8 weeks?
3 weeks. 3 weeks of oliguria is the upper limit at which a patient should go into a diuretic phase. If after 3 weeks there is no diuresis, you're justified in going for a biopsy to look for acute cortical necrosis. In case you want to postpone a biopsy, you want to look through non-invasive methods, then do a contrast enhanced CT scan.
Another one, sir. Can patient have normal platelets or no schistocytes and have atypical HUS?
Yes, that can happen, particularly in patients who come late to you, because these abnormalities last only a few days. The low platelets, the schistocytes, the LDH levels, these may last only 5 to 7 days or 2 weeks or something like that. So by the time the patient comes to you, if it is too late, they may disappear. So it's certainly possible for these to be absent by the time the patient reaches you.
Another one is when to suspect AIN and how to approach or evaluate.
If you have a history of exposure to a drug which is known to cause AIN, for instance, one of the commonest groups of drugs which cause AIN is NSAIDs. I'm sure all of you know that. So if a patient has been on an NSAID, like aceclofenac, which is very commonly used NSAID nowadays, so obviously it means that you need to consider this possibility, and you have 2 options. If the patient agrees for a biopsy, yes, do a biopsy. If the patient doesn't agree for a biopsy, give him a trial of 1 milligram per kilogram of oral steroids and see the response. Things looking for eosinophilia, looking for other things like a skin rash, those are rarely present. They don't help. So therefore, just a high index of suspicion is very important, taking a careful history. If a patient has been on a drug, say like rifampicin, again, think of acute interstitial nephritis. So The history is the most important parameter. Nothing else may help you.
I suppose there is one more question. How do we manage a patient with AKI on hemodialysis to prevent more ischemic damage to the tubules?
The only thing important while you're doing hemodialysis is don't do too much ultrafiltration. I find this a problem whenever a patient is in the medical ICU. The ICU staff, the physicians in charge of the ICU, these are usually anesthetists or pulmonary physicians, and they insist on excessive ultrafiltration or fluid removal during dialysis, and they make the patient oliguric because the patient goes into fluid depletion. And this particularly happens in patients who are on ventilators. They think that the only way to get the patient off a ventilator is by dehydrating him. So they may be correct up to a certain point, but if you overdo it, then you are bound to cause further insult to the patient's kidneys.
The next question is, how does COVID-19 affect kidney function?
Well, COVID-19 is, this is something we don't understand fully as yet. There has been a suspicion, there's been a suggestion from some studies that COVID-19, the virus itself may reach the kidneys and may affect, may cause kidney injury. However, this is not something that has been confirmed convincingly. So there are still serious doubts that remain. There may be also injury caused through various cytokines. There may be bacterial sepsis. So there may be multiple mechanisms of injury. We don't as yet understand all these. So maybe we need more studies before we will be able to answer that question convincingly.
Another question is, if patient would have granulomatous lesions, biopsy causing AIN, what would be the approach to rule out TB or sarcoid?
That's very straightforward. If you're looking for tuberculosis, look for acid-fast bacilli. Look for tuberculosis elsewhere in the body, in the lungs, for instance, or lymph nodes. So look for acid-fast bacilli in the kidney, in the horn histology, and look for acid-fast bacilli in the morning sample of urine. And if you can find them, give a course of antituberculous therapy. If you're thinking of sarcoidosis, look at the ACE levels, look at the serum calcium levels, look at the renal histology for calcium deposition, any effects of hypercalcemia on that kidney. So that is what I would do, look at the ACE levels.
Is there any role of plasma exchange in patients with Shiga toxin-induced HUS?
Very, very doubtful. I don't think I would consider it as the first line of therapy. The usual line of therapy in Shiga toxin-induced disease is conservative management. There is, in my opinion, not really a significant role of plasmapheresis. A significant proof is not there.
Role of plasmapheresis in rhabdomyolysis?
As far as I'm aware, no proven role. I'm not aware of any recent data, if any, which indicates a role in rhabdomyolysis.
Sir, I suppose this is the last question. There are no questions anymore.
Right. So then we'll call it a day. But if anybody has any questions that arise later, they are welcome to get in touch with me through email, and I'll be happy to take up Any further questions?
Excuse me, sir. Excuse me.
Yes.
Good evening, sir. This is Dr. Abhishek. I'm a nephrology resident. If I could ask you a question which was a little off topic.
Yes.
Sir, if you can, this is about this term acute kidney disease.
Yes.
Sir, my question is, sir, how would you use it for diagnosis and also for patients during exams? And also, sir, where does this new term fit in terms of the nephrologic syndromes that we classically use in classifying our patients?
See, that's very clear cut. The term acute kidney disease, AKD, is meant for patients who had an episode of AKI, which did not recover in 7 days' time. And if less than 3 months have elapsed since the start of the injury, and the patient still has not completely recovered, that is called AKD. If
Okay.
it lasts more than 3 months,
That
you call
becomes
it,
CKD.
it becomes CKD.
Yeah.
So currently, this is a new term that is being used. Its usage may change, its definition may change. So
Yes, sir.
this is the usage at the present moment.
Okay.
We yet have to see what might happen to this in future.
Okay. Thank you, sir.
Right. So with that, I'd like to thank Puneet once again for having anchored this session and having made all the arrangements. Once again, thanks to Dr. Vijay Kher for the kind invitation, and thanks to all the students who have attended this session. Thank you very much indeed. Hope to
It's
see you
entirely
soon.
our pleasure, sir. Students are really fortunate to have you every time.
Thank
sir.
you.
And thanks
Thank
for
you
Dr.
very
K,
much
sir.
indeed.
Thank you.
Thank you very much. Thanks a lot. Okay.